Thank you. Hi there, everyone. My name is Pam Yankeelove, and I'm the Director of Research and Evaluation at the University of Louisville Traeger Institute. And we are so glad you are here for our Project ECHO, Care of Older Adults. That's in partnership with the Kentucky Coalition for Healthy Communities. And just some tips today. We ask that if you can, go on and turn your camera on so we get to a sense of who is in our Project ECHO community. You can go on and check your mic by using those little things that are pointing there at the end of corner of your camera there. If you're having any difficulties with your mic or your video, please go on and stay with us. Go on and check those things. And then if you get kicked off, you can always join us by phone or by your Zoom app on your smartphone. So Project ECHO is a partnership between the Community Coalition for Healthy Communities and the Traeger Institute. So we were hoping to have, I think, Chelsea Maselli go on and tell us a little bit about the Kentucky Coalition for Healthy Communities.
Hi, guys. KCHC is here to create community support systems for older adults in partnership with existing local coalitions and organizations. We assist in developing workforce and concerned community members to empower our communities to become healthier. And thank you for being here today. And thank you for supporting Project ECHO.
All right, thank you, Chelsea. So if you're unfamiliar with Project ECHO was developed about 15 or 16 years ago by Dr. Sanjeev Arora, and he is an MD. He's a hepatitis C expert from the University of New Mexico. And he developed this platform. It's a telementoring platform. And the idea is to actually move knowledge, not patients. He had patients that were coming from 200 to 300 miles away, and he realized he wasn't really creating local capacity. All he was doing was giving one patient appointment to another patient. So he developed this platform called Project ECHO, and it is a telementoring platform. The idea is that you have a didactic and then you have a case. Then you work together as a teach all, learn all community. So in our particular Project ECHO, we're focusing on best practices in interdisciplinary team-based care for the care of older adults. So today, and we're going to go on and ask that you go on and we're going to take attendance. We're going to ask that you go on and put your name and your affiliation in the chat so we can get to know one another. And if you have yet to do so, we ask that you go in and put your name underneath your video square and go on and put your organization there as well, just as I said, so we can get to know one another. All righty. Thank you, as everyone's putting their names in there. So our presenters have nothing to disclose. And if you are a community health worker, we do have this session approved by the Kentucky Office of Community Health Worker. You'll receive 1.5 CEUs if you are a certified community health worker. You just have to make sure you go on and complete the survey at the end. If you would like an attendance certificate for the 1.5 hours today, please go on as well, complete the evaluation. But those community health workers, you got to make sure you complete your evaluation to receive your CEU certificate. All right, our didactic presentation is on older adults and the criminal legal system. So let me tell you a little bit about our presenter. We have Dr. Stephanie Grace Prost with us today, and she aims to promote health and the quality of life among criminal justice system constituencies, specifically older persons and persons with life-limiting illnesses who are incarcerated and their caregivers in carceral spaces. Her work has been funded by the Aging Research and Criminal Justice and Health Network via the National Institutes on Aging and the National Institutes of Health Justice Community Opioid Innovation Network Learning Experiences to Advance Practice Investigator Track. She pursues this aim using qualitative and quantitative methods and is currently developing a tailored intervention to improve chronic disease self-management among older adults who have returned to their community from incarceration. So we are so thrilled to have you today. We were talking earlier that we haven't had anything as it relates to the criminal legal system. So we're so glad that you're with us today. And you
Thank you so much for the invitation. I appreciate it. And I will offer that I'm also joined by one of our doctoral students, Mr. Daniel Bowman, and give us a thumbs up. Or there you go, wave, excellent. We hail from the CLASS lab, which is the Criminal Legal and Social Systems lab here at the University of Louisville, Kent School of Social Work and Family Science. So as a sort of disclosure of sorts, just want to acknowledge that the research presented today has been funded in part by the following agencies, both internal and external to the University of Louisville. And perhaps most critically, we acknowledge the Kentucky Department of Corrections participation in our work. However, our findings from the studies are neither approved nor endorsed by the Kentucky Department of Corrections. All right, a quick overview of what it is that we are up against today. I'll give you a bit of background, which really lays the foundation for the work we've been doing here with the older adults in Kentucky State Prisons study, or the OAK study. And then we'll pause a bit to think through some of the implications, most especially kind of in the practice domain. And here we'll hear from Dr. Webb regarding specifically the end of life options for folks who are in these spaces. We'll kind of round that fourth turn there with a case presentation that I've developed sort of as a combination of cases I've worked on with families against mandatory minimums named Bonnie. Talk a little bit about Bonnie. All right. So the giants on whose shoulders we stand have spent the past really 50 years documenting the large and growing population of older adults in correctional institutions throughout the United States. So as it stands, we have about 15% of all persons who are incarcerated in the state or federal prison system. That's generally about a year and a day or longer, equating to about 25,000 persons at 2021 year end. This is a population that is understood to be shaped in large part by not only the aging of the general population, but also by increased arrests among older adults, as well as the kind of long-term effects of the wars on crime and drugs. The population is well understood to experience what is known as accelerated aging. So it's a biophysiological process by which individuals demonstrate the characteristics of persons much older than they are chronologically, in part due to experiences of the correctional setting itself, but also potentially exacerbated by pre-incarceration experiences such as community violence, food deserts, and those sorts. This leads to a heavy health burden. We see earlier and more frequent functional and cognitive impairment among the population, and an earlier onset of chronic disease and geriatric conditions. Recent systematic review reveals very few supports for the population during their incarceration. And because of the sentencing structures in many states and throughout the federal government, many individuals will die behind bars. We also are aware that there are very few tailored reentry approaches. Perhaps the most prominent is the Elder Reentry Initiative that's housed in New York State, that partners with city jails, as well as state institutions prior to a person's reentry to enhance continuity of care, as well as making connections post-incarceration with appropriate providers in the community. The short of the long of it, however, is that most communities are reticent and underprepared to meet the needs of the population, because here we face the intersecting vulnerabilities and stigmas associated not only with ageism, but also with criminal legal system involvement. That brings us to the OAK study. So OAKs are prevalent throughout the world. They are both deciduous and evergreen, and they represent the diversity, intersectionality, and resilience, I think, of older persons. The oak study also centers on the idea that oaks as trees are keystone species. They are absolutely essential to the survival of other groups. And for this reason, when we started this project, we wanted to center the voices of these folks, recognizing that they have a long-standing influence not only behind, but beyond the bars. The OAK study is a two-phase sequential mixed method and longitudinal effort. Here we seek to catalog the health, life quality, and justice-related experiences of older persons in Kentucky prisons, as well as the existing limits and strengths of programming and services in Kentucky prisons. We spent 2 years speaking with individuals aged 45 or older face-to-face across 5 institutions and multiple classifications, including our women's institution here in Pewee Valley. Going to spend a little bit of time talking about some of the more recent publications born of this study, so as to provide kind of an extension of the foundation laid again earlier in the background slides. We'll start with this kind of first empirical exploration of the data collected during the 2018-2019 survey portion of the study. So in terms of older adults who are here in Kentucky prisons, this particular sample represents just those incarcerated at the Kentucky State Reformatory. We found that based on our analysis, the chronic health condition frequency was actually higher than parallel samples with older adults throughout the country who were incarcerated. We also found a greater proportion of individuals who were experiencing 4 or more chronic conditions, that sort of measure of multimorbidity, as well as elevated post-traumatic stress and depression scores using standardized measures, including the PHQ-8 and the PCL-5. Broadly, functional impairment increased with age, and post-traumatic stress decreased with age across the cohorts. We found this particularly important as the legislators and the public often justify limiting the release of individuals who are older or from these correctional settings due to the fear of reoffense. We found that these differences emerged across cohorts. So of course, you all know this as older adult practitioners, that older adults are not a monolith. But importantly, the mean age for this particular study was actually quite young. It was in the early 50s, which means that the health-related burden we see in the population is anticipated to increase. As we continued our exploration, a project spearheaded by a colleague here in the Kent School of Social Work related to social capital. This is kind of an ever-present model in social work practice, understanding how individuals are engaged with one another and how those connections lead to not only social and educational outcomes, but also to health-related consequences as well. So we recognize that individuals rely on one another to navigate healthcare systems who are in the community. That's true for our older adults as well. You might be familiar likewise with the convoy model. So this exploration of individuals incarcerated at Luther Luckett, which is out here in Oldham County, revealed that as trust increased among older adults who were incarcerated, we also saw an increase in depression. And this is after controlling for common correlates of depressive symptoms in the population. This becomes incredibly important as trust is critical, again, to navigating healthcare systems. And so what individuals in this space were saying is that as they began to lean on members of their social network, their health actually decreased. This becomes particularly important as individuals are navigating the continuity of care post-release. As we continued our exploration, we centered some of our work on our older women. And so this is actually kind of uncharted territory for many scholars at the intersection of aging and criminal legal system health. So this study represents a sample drawn from the Kentucky Correctional Institution for Women. Overarching findings relate that 2/3 of the population have experienced sexual assault, other unwanted sexual experiences, or having been held captive prior to their incarceration. The mean score of the entire sample exceeded the cutoff for a preliminary diagnosis of post-traumatic stress using the PCL-5. And we found here that individuals who reported these experiences were far more likely to rate their depression, post-traumatic stress, and life quality as worse than those who had not had such traumatic experiences. We also found that those who had reported the traumatic experiences were also likely to report lower environmental quality of life. These findings buttress those put forth by Salisbury and Van Voorhees in 2009, seminal work in our understanding of gendered pathways to incarceration. The short of the long of it is, men and women make their way to incarceration for different reasons. Likewise, their experiences during their incarceration are disparate, as are their reentry prospects. What we found is evidence of the role of social and human capital as deeply integrated within victimization models, again, put forth by Salisbury and colleagues. One of our most recent explorations relates to secondary data that was merged alongside our survey data to examine the influence of visitation, which is a common measure of social support within criminal legal systems, and older adults' health. Existing scholarship in this area does relate visitation as linked to mental health among younger persons. However, an exploration with older adults had yet to be conducted. One of the additional sort of exploration strengths is that we looked at how these measures were linked to one another based on self-identified racial subgroups. So this particular analysis actually joins samples from both Luther Luckett and the Kentucky State Penitentiary, which is home to death row here in Kentucky. So broadly speaking, we found that 70% of all older people who were incarcerated, which is an average of 12 years in our sample, had received 0 visits during the length of their incarceration. Among those who did, the average visitation, was about 4, which relates to about a visit per year. Once we took a closer look, we also found that group level of variation using an ADA coefficient was that variation in visitation in terms of how often people came and the people who were visiting was instrumental to older adults' self-reported mental health. We also found significant differences in those who were white or non-white in our study sample, and the impacts of visitation on subgroups was also disparate, meaning we found that as increased visits occurred among white older adults, we saw improved health. And as visits increased among our non-white subgroup, we saw a decrease in health. So we'll talk a little bit about why that might possibly be. Some evidence exists regarding the role of secondary prisonization among older people broadly, as well as their family who were coming to see them in these institutions. So we believe that there is likely an inverted response for older persons who are non-white, in that as their family members make their way into these spaces, they too are subject to discrimination, sort of a victimization of sorts as they enter these spaces. While that data was not collected, that is a clear research implication for our team as we move forward. One of the final studies that I actually think is most exciting represents the largest kind of empirical sample we have of older adults who are incarcerated in the United States, collected via primary data collection. So we do some psychometric analyses here in the class lab with the expectation that there is reason to believe that not all gold standard measures hang so well within varying samples and settings. And so we found the need to explore the role of the WHO breath, which is a kind of a gold standard measure of life quality among older persons within this particular space. So because intervention is contingent on measurement, we examined the most common applied measure, again, the WHO, which is used internationally in samples of incarcerated persons. We actually found adequate reliability and structure within this space, but important implications emerged from this study in that the Department of Corrections dictates those questions that can and cannot be asked. And several of the items in the WHO breath include related queries surrounding sexual health. And we'll talk a bit about that in our case presentation. The Prison Rape Elimination Act, in effect, dictates that no sexual contact can take place within correctional settings because consent is not possible in this particular environment. It's hierarchical in terms of coercion. And so for this reason, several items surrounding one's social relationships had to be removed. So we make the case that co-conceptualization alongside older persons in prison will be essential to understanding what life quality truly means in this space. Excellent. All right. So what's it all mean? So there's tons of research implications I'll offer that I think we've raised more questions than we've answered, but a couple of pertinent findings, a couple of pertinent implications arise, most especially surrounding practice. So as a social worker by training with experience in criminal legal systems, we acknowledge a great need to enhance the criminal legal system awareness, knowledge, and skills of our gerontological workforce. That includes people in areas on agency AAAs, excuse me, AAAs, as well as other agencies that don't traditionally work with older adults who might be interfacing with those criminal legal system populations. Places like rehabilitation centers, drug rehab, reentry spaces, or halfway houses. I think another important implication, because of the sentencing structures, not only in Kentucky, but throughout the Mid-South, we want to make it explicit that many individuals who are in these spaces, despite not serving life without the opportunity for parole sentences, are likely to meet their natural death within these spaces. And so I'm going to take a few minutes here and turn it over to Dr. Webb to talk a bit about the end-of-life care experiences of the population.
Dr. Webb, I think you need to unmute.
Okay. Thank you. I have been one of the medical officers of the hospice in Louisville, and about 25 years ago, we were approached by a chaplain from the Kentucky State Reformatory who spoke to one of the hospice chaplains whether he was concerned that he would like to see some additional care, some hospice care for the inmates who were dying in the prison reformatory. And so they got together and worked up a program. There were not many programs at that particular time. And they found out that trying to get a typical hospice team into the prison system to take care of these patients was impossible, because the prisons hire companies to take care of their medical care, and they didn't want other people coming in and causing problems between the two groups. But there was at that particular time a program in Angola prison, which is a maximum security prison in Louisiana, of using hospice prison inmates as hospice volunteers. And so they went ahead and set up a program along with that, and presented it to the then warden of the Kentucky State Reformatory, and he turned it down. And so for 2 years, nothing happened. But when a new warden came in, he saw the program and approved it and liked it. And so we started it at Kentucky State Reformatory. They put out a call for inmate volunteers who would like to participate as hospice volunteers. And these inmates who said they were interested were then screened by the prison authorities. They had to have a completely clean history in the prison, and then we went in as a group and trained them to be hospice volunteers. Essentially, the same type of training we gave our volunteers who are out in the public. And at the start, their main purpose was, if there was an inmate who was admitted to the infirmary who was in the quote active dying process, there would be a hospice volunteer who would be sitting with them 24 hours a day. They did this on 8-hour shifts, and this was in addition to the other jobs that the prisoners had to have. And this really turned out to be a very effective program, and the inmate volunteers really enjoyed being able to taking part of this. And it turned out actually that eventually they also turned out to be palliative care volunteers, because they would find other prisoners who were diagnosed with end of life diseases, and get acquainted with them and meet with them before they were at the point that they had to be admitted to the infirmary when they were actively dying. This program went on very successfully. Somebody from the hospice would go in every bi-monthly and meet with these volunteers. First of all, they listened to what they had what they've been done and what problems they had encountered, and do what we could to resolve some of those problems. And then we would do additional training also during that period of time. And this program was very successful. We really thought it was a good program, but unfortunately, KSR closed their doors recently, and there's no longer a prison there. But about the time that we had to close the program at KSR, we got a request from the women's prison, which is in Pewee Valley, to set up a volunteer program for them. And so we have gone ahead and done that. And that program, again, seems to be doing very well. These people are in prison because they've done something bad, sure, and they're in prison because that's their punishment. But if they reach the end of their life, we felt it was just that they should also have some compassionate care and some improved quality of life at the end of their life.
Thank you for that, Dr. Webb. And I think you and I might be due for coffee after this meeting. So yes, so obvious practice implications both behind and beyond the bars for those individuals prior to end of life care or life limiting disease. All right. Excellent. Thank you, Justin. So I'll also kind of recognize that an additional implication specifically for Jefferson County or the greater Louisville metropolitan area is understanding and preparing for the reentry of older persons from our state prisons. Actually, in the potential opportunity to partner with Traeger, we are launching a study that's funded in part by NIH to understand the experiences of re-entered seniors, those who are back in the communities, those things that work, those things that don't work, and how their chronic disease self-management may be enhanced post-incarceration. So we are currently recruiting, doing interviews as well as focus groups with older persons aged 45 or older with at least one chronic health condition to learn from them those perspectives so as to develop, deploy, and evaluate a tailored psychoeducational intervention for folks returning from Kentucky prisons locally. Excellent. All right, so there's the insight regarding kind of the empirical foundations as well as efforts currently fostered by the class lab here in Jefferson County. I'm going to pivot now to Mr. Bowman, and he's going to walk us through kind of a typical / atypical case. Miss Bonnie.
Thank you, Dr. Prost. So this case includes several common challenges encountered by older persons who are incarcerated. And in many ways, like Dr. Prost shared, that this is a pretty typical case. Additional facets were included to highlight some unique challenges for persons with felony convictions. And we hope that those of you working with older persons returning from prison recognize and respond to, via individual or macro level advocacy, the complications introduced for those making their way into the community from a carceral setting. So let's meet Bonnie here. Bonnie is a 62-year-old white female who identifies as cisgender and heterosexual. She currently serving a 15-year sentence in the general population with the opportunity for parole in a Missouri state prison. Early childhood victimization and later intimate partner violence contributed in part to Bonnie's misuse of alcohol and subsequent conviction. The alcohol misuse and genetic precursors she has have subsequently led to decreasing kidney function and liver failure, as revealed via recent annual checkups at the prison. Her condition has deteriorated in recent months, but she has received emotional and physical support from several women in her dorm. She has been able to receive dialysis on site multiple days per week for several hours of treatment, per treatment, and she has made parole and is slotted for a release in September of this year in 2024, but is required to register as related to a sexual offense upon release. Let's see. Oh, Bonnie's primary diagnosis includes kidney disease, liver disease, hypertension, and diabetes. She also reports she has been diagnosed with post-traumatic stress and depression. She further offers that she believes that she has some form of sleep disorder as she has trouble falling and staying asleep. Bonnie is approximately 5'4" with a BMI of 30.9, and her most recent blood pressure while on medication is 135/80. Bonnie relates or reports that she enjoys school very much and likes watching educational television, such as programming about U.S. history and wildlife when it's presented to her. Because Bonnie was principally a stay-at-home mom, prior to her incarceration, she has not paid into the system, so to speak. She's never held a job that withdrew Medicaid or Social Security and paid into it, and thus would not qualify for some level of social supports upon her release. Bonnie is estranged from her grown children since her conviction. She was not married to their father. They did have a common law marriage and cohabitated together for several years before the birth of her first child, but then separated after her incarceration began. While Bonnie does not have ready access to the volume of alcohol previously consumed prior to her incarceration, she does indicate that there is access to homemade alcohols while incarcerated, but they do come at a very high price. So for health services, while access is in place, uh, through the case precedent Estelle versus Gamble 1976, satisfaction with care is poor overall. So while care is provided, it's not necessarily provided timely, or the greatest of quality. Bonnie relates that this is principally related to delays, the length between her requests. So she has to put in a chit requesting service, and then it makes its way through the bureaucracy and then comes back down. And oftentimes, triage is maintained through staffing levels, and services that are available at her facility, and then the cost of sending her off-site if that were necessary. And then to an extent, the cost to herself. So right now at her facility, she has to pay a $3 copay no matter whether the issue is actually managed. Just to be able to see the doctor, it costs her $3. And she is only allowed to talk about one issue per visit. So if she has multiple issues, she can only do one per visit. Uh, while $3 doesn't sound terrible for a copay compared to what we might pay out here, it should be noted that folks that are incarcerated at her facility earn between 5 cents to 30 cents per hour. So a single copay could take up her entire day's pay, uh, you know, maybe even several days, depending on what her pay scale is at. So the environment, while her home hygiene in and around her bunk is very good, she keeps a very tidy space. Bonnie does share that the overall prison environment is poor. She relates that the showers never come clean and that areas around the commodes are very grimy and filthy. She also notes that the airflow is very limited, oftentimes very little heat or air conditioning coming through, depending on the seasons, comes through the vents, and that classrooms and dorms are often marked by mildew, with carpet in some places having visible mold. Uh, it's important to note that a lot of these facilities that individuals are being housed at, especially older individuals, I mean, some were built nearly 200 years ago. Even in the case of newer prison facilities, we're talking about the 90s to the 2000s during the prison boom that they were built. So a lot of these facilities, even on the back end, are at least 20 years old at the newest. And they are hard, this is hard architecture. So very likely to have fall hazards. Many of them have been repurposed or hastily remodeled to accommodate the new needs of the state. And so Bonnie has recounted the prison environment is very stressful. While she has not been witness to violence by staff towards those who are incarcerated, she has recounted a great deal of conflict among women in her dorm, and especially bearing witness to self-harm among the population. She notes this has caused her great distress and has impacted her ability to sleep. Whenever she hears largely doors or officers yelling to roll doors, open doors, especially in the middle of the night, she fears that one of her friends or someone that she cares about may have caused self-harm to themselves. And while Bonnie is separated and estranged from her family, she does have friends within her dorm. However, she is worried about re-entering without their support. She's excited about going home into the community. However, prison policy and along with parole and probation prevent her from being able to call or write letters back to the individuals who will remain incarcerated after she's released. And she's also worried about what registering with SORNA means for her housing and future relationships.
Thank you so much for that, Daniel. And I recognize that some of the policies might be new to folks who are working principally in the community and with older adults more narrowly. Daniel just made reference to SORNA, which is the Sexual Offender Registration and Notification Act. That's a federal policy that dictates kind of parallel approaches at the state level regarding where individuals can live, what types of employment they can hold, expectations surrounding their notification if they move, those sorts of things. And likewise, we made mention earlier of PREA, that's the Prison Rape Elimination Act. And to Dr. Webb's point, I actually wanted to offer that when we're doing work with our peer caregivers as well, this comes up a lot. We're working on a paper now where peer caregivers have kind of acknowledged that their fear of, quote, catching a PREA can actually keep them from intervening in ways that would likely be essential to assuring activities of daily living among the population, risks to ambulation, things of that sort. If you are to be found guilty of a PREA-related offense, while you're incarcerated, that is a federal charge. So in addition to your state incarceration, you would then secure a federal charge. So I'm hopeful that clarifies some of the acronyms that we were using.
Thank you so much. So there's lots of sort of things swirling around in my brain. Is there any comments or questions for the group of colleagues? Anything that you were, surprised by? I think I was surprised by the lack of visits, that 70% of individuals had no visits. And then I was surprised that the visits that did happen, that there was differential impact on those that were white versus those that were non-white. And I think I missed your perspective on that. Can you share that again?
Yeah, absolutely. And I apologize. I'm easily distracted in my home environment. So if I wasn't clear.
I don't think it was you. There's so much to take
yeah. So there's some existing scholarship around this idea of secondary prisonization, which is the kind of negative experience that friends and family, especially not really attorneys, face during visits with people who are incarcerated. So kind of being subject to the same dehumanization, again, discriminatory practices, offhanded remarks from custody staff, just kind of a sense that they are sharing in the incarceration of their loved one. So like they're being treated as if they are also in prison. So that scholarship kind of relates a few things. One, that the visitation experience, although often considered a positive indicator of social support, right? Because more visits can often enhance social capital, which means better access to housing and employment post-release. Visits can be really stressful. So we're kind of having this increased understanding of the nuance of visits. And in part, because folks who are coming to visit their loved ones may be subject to these negative interactions. And so perhaps our older adults are saying, these individuals are coming in, they're being treated like garbage. And thus, I would rather either they not come at all, or they end up having these sort of negative psychological or emotional responses on the back end of visitation. So what we found was that among our white older adults, that as increases in visitation were documented, we saw increases in mental health, but it was inverted for our non-white folks, so that as visitation increased, we saw a decrease in mental health. And so of course, we didn't collect this information about secondary prisonization. We had this sort of thought that it's perhaps because non-white older adults who potentially, because of social homophily, likely have non-white friends and family, those folks are subject to a secondary prisonization experience that might be disparate from their white counterparts, which leads to these negative interactions.
Yes. It was also interesting to me about how it is that here you have made, all these connections with your peers and support, and then you leave prison and you're cut off from that.
Right. Yeah. And
So,
fictive kin in prisons, most especially for those with those lengthy, or virtual life prison sentences, things like 50, 75, 150 years. That is often family. And I think Dr. Webb could probably relate similarly when we find this same thing among our caregivers too. I mean, these folks know one another with an intimacy that we can't necessarily mirror in the community. And then we take that away because of the sort of iatrogenic criminogenic effects. That's what they say. Like, you're at an increased likelihood of reoffense if you remain in contact with the person inside.
yeah. Were there comments in the chat?
Tina has a question.
Yes, Tina.
I have a comment. You said your question was, did we learn anything new? I was really surprised to see that they have a copay for medical care. And if they could only discuss one thing at a time, it's like they're just working against them. So what if you have, sore throat and a chest pains? You're just
Yeah.
going to talk, I just think that's unfair.
I appreciate your comment, Tina. You're like, at what point have we ever gone to a GP and been like, I just have this one problem. I haven't seen you in 6 months, but can we talk about my toenail? And Daniel could likely speak to this as well. I think there's some evidence. So I have a dear colleague who's at Cleveland State. Her name's Megan Novisky, a gifted qualitative researcher who's done hundreds of in-depth interviews with older people in prison. And she recently published a paper, Tina, about this sort of underground healthcare economy in prison. And kind of like FUBU, like for us, by us, they have to take healthcare into their own hands. And so they are often instrumental to kind of like peer-based education. Even if it's not in a structured environment, they might have a friend on the outside. They're getting insights through their tablets. They're like, hey, my brother's a doctor, or hey, my brother's a CNA. Let me find out for you. And so we've heard informally that many folks will leverage their social networks to manage their health-related conditions in the spaces because of the structural issues that exist, principally with contracted healthcare providers, which again echoes Dr. Webb's point about there is this unique controversy, this dichotomy between care and custody in these spaces. We have contracted healthcare providers who are often trying to provide care at the lowest cost possible because there's a profit to be made. And so there isn't always an incentive to assure that every single issue is managed, at least in a single visit. Also, we know informally that individuals are very rarely referred for specialty care and off-site visits as well, because that increases costs. Things with ambulance visits, anything that's off-site in terms of transportation and security, right? Because you have to often send no less than one correctional officer, but potentially two, depending on the classification level. We've seen people wheeled out of KSR who are not even alert and oriented, who have to be accompanied by two officers because their classification's maximum. Good comment, though.
Yeah. I have another question about when KRS closed and you went to the women's prison for educating individuals to be, hospice workers. Did you have to do any additional training as it related to working with individuals that had Alzheimer's disease or related dementias? Was there an uptake there as it relates to anything like that? Did you notice that?
We would do sessions and have people come out with us to give them some training on dementia and dementia related diseases, so they could hopefully communicate better with the people they were dealing with. Yeah, and frequently we would, when they would visit somebody and they would come up with a particular problem, either regarding that disease or regarding communicating with the person, then during our next monthly visit, we would try to bring somebody along to address those problems for them.
Yeah, I just asked that question because, women are twice as likely to have Alzheimer's. And I thought, I wonder if it was going to be a different experience working in the women's prison.
And they do have like a dementia unit for the men's institution, because there's kind of an increased continuum of care in the women's institution. They have additional structure, so they almost have they've got assisted living, they've got a nursing, and then they have sort of this hospice end of life care space, because they've structured it in dorms. So rather than those folks remaining in the general population, they're kind of all in one space. And so the care workers that are in that space have been working with folks with ADRD. We just went in September, and one of the pieces of feedback we got from peer carers was, we would love more training. Like, we'll take it, anything that you can give us. And dementia definitely came up. But we have found, at least between caregivers and men, and differences in caregiving between men and women, women are often well equipped in terms of their knowledge and skills prior to their incarceration. And so many of them are kind of coming to the table having either cared informally for a loved one before. They just have at least somewhat of a command of parallel dementia. Syphilis-induced dementia is also prevalent in the population too.
Yeah. That's interesting about the caregivers. Okay. Other
So-
questions? Yes.
Yeah, I have a question, and I was thinking about this throughout, for those that are in that caregiver role, caretaker role, post-release. So say they have this experience of where they have been working in these roles, but we know being able to go get a job at a nursing facility is probably not on the table because of the background. Is there any programs nationwide that take this specific population and then when they're reintroduced, use them caring in this capacity for others that may have been post-release? Does that make sense? I'm just thinking, is there any programs like that you know of?
So we've been shouting at the rooftops about that. Like, why would you forego this tailored knowledge and skill set, either whether they're working in the community with non-correctional settings or they're actually back in the prisons? So the biggest barrier is that many public and private healthcare agencies will not allow individuals to work in a direct healthcare capacity with a felony conviction, period. So that's kind of an overarching national trend. There are fewer second chance employers in healthcare, as you can imagine, potentially.
Right.
And so what we do find is that folks may go into informal caregiving roles or under the table sort of roles.
Sure.
But to Dr. Webb's point earlier about Angola, the Louisiana State Penitentiary at Angola is the largest maximum security prison in the world. It's 6,000 people on a given day. Their hospice unit is pretty big, and it's only 12 beds. But they have individuals who are providing this comprehensive peer care, but many of them are not parole eligible, so they're not going home.
Right. And it's interesting you all mentioned that, because was there not there was a special about the hospice unit at Angola, wasn't there?
Yeah.
Okay,
Yeah.
I remember seeing that, and when you all were
Oprah.
talking,
Yeah.
because and that is another point. I just think that is the need for caregivers in the general, let's just say in society in general,
Yeah.
is astronomical.
Yes.
And then we have these people with the skill set, yet we there's all these bureaucratic things that we can't utilize them. And so,
Yes.
I just went down a rabbit hole while you guys were
No,
talking.
I think that it's not a rabbit hole. So the documentary is Serving Life, and there's actually another one on prison hospice about a particular case, but we show that in our death and grief class here in the Kent School. We could talk for hours and hours about this particular issue. We have empirical support that not only are peer caregivers good at what they do, but they have an intimate awareness of their patient's experience that's unlike what we even see in the community. I made mention of it earlier. We actually quantify their ability to match their patient self-report across standardized measures, and the gap, the inter-rater agreement, is very high. They know what's going on. And so for me, as a practitioner, I'm like, look, I can show you how good they are. In fact, better than some scholarship in parallel caregiving fields would argue. And yet they don't even allow them to provide insight to the interdisciplinary team in the prison.
Oh,
So it's kind of like there's this known unknown, or there's this sort of comfortable awareness with just like, we want you to do this work, we don't want to take your insights, you still remain kind of a second class citizen, if at all, or unhuman in the context of care. We need you to do the grunt work, but we're not going to assume that you have any expertise. Daniel, it looks like your hand's up.
Yeah, I was just going to add to that. So among community health workers, and several of the folks on the call might be familiar with it, there are certain specializations like forensic CHWs, peer support specialists, and peer recovery specialists that oftentimes, like in Indiana, requires some form of conflict with the legal system, some level of lived experience with these issues. The problem being is that even in like a large county like Marion County, Indianapolis, the health department's only going to have like 2 positions, despite having 200 CHWs on staff that are only going to open up 2 for these very particular cases. So even when we do find roles for individuals with a criminal history, they're very few and far between. And so you have a large pool of people who would be, competing for those roles.
yeah. We at the Traeger Institute, we have a HRSA grant that's focused on infusing paraprofessionals into primary care. And part of the program is to help individuals get their peer support specialist certification and their community health worker certification. And half of our folks go into apprenticeship programs in primary care, but some of our folks also have the background that you're speaking of. And we've, had to deal with that, as Stephanie and you are talking about. Can I ask one question too about how long has these programs been going on in the prison as it relates to the caregivers, creating colleagues and your peers as caregivers? Is that 20 years? Is that 10 years?
Peer caregiving broadly within
No,
corrections?
I mean within the prison.
So I can't speak to Kentucky's program. I mean, KSP has peer caregivers that work in a variety of capacities. In their actual hospice unit, to Dr. Webb's point, they've been in multiple institutions for 10 or so years. There's been gaps. The Louisiana State Penitentiary at Angola has had peer caregivers since the 90s. The challenge, though, I mean, there's 1,000 challenges. One that's become particularly salient is the National Commission on Correctional Healthcare, NCCHC, which is a voluntary accreditation that prison healthcare agencies can seek, prison healthcare settings can seek, actually has policy dictate that says other people who are incarcerated cannot be instrumental to the care of other people. And so you have this competing sort of challenge where you're like, prison administrators are very clearly aware of the need from like the just basic assistance, like things like, can someone please get this person down to chow? Like not even really intensive caregiving, to the more kind of ADL, basic support, ambulation and transfer, that sort of stuff. And then also recognizing that they're like in direct violation. Again, if they're seeking NCCHC accreditation or they have accreditation, it's kind of like an open secret in many ways, where we've actually heard administrators, not necessarily in Kentucky, but kind of more broadly say like, hey, we understand that we're in this pinch, which is we have far too many people for whom we can provide care. Our staffing issues, both in the correctional health realm as well as correctional staff, like the custody staff or programming staff, they're so low. Women, when we were doing our interviews, would say they can't stand the middlemen challenge that they often face, which is they can't intervene. They cannot provide care without there being custody staff around. That's to protect people, right? We don't want folks to be subject to victimization or even just, like poor practice, professional practice. And so someone's having an emergency. agency dictates is they cannot touch that person until there's a CO around. And so you have this constant sort of tension where people want to intervene, they want to support one another, and they're fearful either again of the PREA related issues or having disciplinary infractions, which potentially puts their parole in question if they get written up.
Yeah, it's just a very interesting.
Which is
social-
really fascinating because, like Dr. Pam was saying, we work with our apprentices. We have quite a few that have been incarcerated for some it's been a short time, for some it's been years. And one of the most traumatic things they talk about is the experience of having someone that they're close with and this isn't particular for older adults, but for a woman that's giving birth, and she may not make it to a hospital, but having to give birth there in the cell, and like them trying to help her, and the officers not coming fast enough, and that truly some of them have been released for years, but they always go back and talk about that. And it's interesting that you brought that up, because I often wonder, I'm like, that's really settled. That's resonated with them in a way that it's almost a trauma that they have witnessed. They have secondary trauma from it. And I just think, how trying to help someone, but you have all this against you, not being able to intervene would be so frustrating. So that makes more sense to me now.
Yeah.
Can I ask, so I want to, there's a question in the chat, and then I have a question about, I'm just going to use Bonnie as an example, but the question in the chat is, how much does their offsite medical care cost them?
So I did just see there were some questions in there. So the offsite medical care in the state of Kentucky isn't something that's paid out of pocket by the person who's receiving the care. It's a charge incurred by the correctional health agency. And so, I actually live out in Oldham County, and so you can see the ambulances leave KSR, Luckett and Rotorua, and make their way into Baptist or Norton or something like that. And so it's not something that the person is paying for, but unless they kind of fell out in their cell or something like that, if they're already in the medical unit, that's just part and parcel with their care. This is just when Daniel was talking about the CHIT, when you make a sick call request, you have to, a portion of your funding is pulled out of your account to see the person. So if there's a medical emergency and you go off site, that's not something you're being charged for.
And so my question is, so let's pretend Bonnie is my aunt. So Bonnie is my aunt.
Yes.
And so let's say I see Bonnie having cognitive changes, and I want to get her some Alzheimer's support. Like, could I act on some kind of way to advocate for her, or could I refer her to the Alzheimer's Association and have the Alzheimer's Association reach out to the prison and try and like get her resources? Like, I'm trying to understand like who would be the intermediary to advocate for Bonnie and
so
get her, like, or if she needed physical therapy, or she needed any of is there any way to get her support from outside into the prison?
So in terms of like, if they wanted to send materials to the niece or the nephew to like educate the people who informally provide support to Bonnie while she's incarcerated, certainly. But just like with, U of L, you can't have, I don't know, Coke or Pepsi. I don't remember who our contract is with. It's a no compete clause. So you can't have other providers coming into the institution. If you've got a correctional healthcare agency that has someone like a geriatrician, right? Or a neuro folks are on the team, it's likely that they're going to seek intervention for that person. They will move them from general population into the medical unit, things like that. And again, at Pee Wee Valley, they do have kind of like a mock continuum of care. But there's only one healthcare provider, and it's just, whatever it is. Like in Missouri, I think the case we use WellPath or Centurion or Corizon or whoever it is. And so it through that agency. It would be great. We actually wrote a viewpoint of sorts a couple months ago about trying to stave off these known problems that are coming. We're kind of staring down the barrel of the gun here. about creating these prison agency partnerships. And we are always advocating for enhanced communication between, these area agencies on aging, Alzheimer's Association, senior centers, right? To prepare not only the people who are incarcerated for their potential release, but to just buttress the knowledge and skills of the staff. But they're at a tipping point, right? Where they've had staffing related issues from prior to COVID. And so they can't even oftentimes host volunteers who want to come in and do the work, because agency dictate is that you have to have at least a certain number of staff to have volunteers on site. It's this whole thing.
So can I ask a question about, so like let's say Bonnie's my aunt and I see something really going awry. Am I going to cause Bonnie more headaches if I potentially raise, if I, if I try to advocate for her in a way that I would in a normal health setting?
Yes. And
she's incarcerated, am I going to cause her more heartache?
So you bring up such an important point. We actually just submitted an NIJ proposal about this very thing, in terms of the risk of elder mistreatment in the population is so high. And they're subject to all these unique circumstances in terms of like dual loyalty and reporting issues. Prisons, police, prisons. So there's no long-term care ombudsman. I have had to make more than one report regarding elder mistreatment. I guess that's the beauty and the beast of this work. And my calls are rejected. They will not take my calls. So APS says that is not under their jurisdiction. We just encourage you to reach to agency channels, like have the person file a grievance. So this is like a known problem that is across institutions across the country. And we don't even know if elder mistreatment is conceptualized the same way. Like that was one of the conversations we were recently having with general counsel at Families Against Mandatory Minimums was, do people even consider it elder mistreatment if you're taking money out of their commissary? Is that financial elder abuse like it would be in the community, or is that just part and parcel with the prison ecology? And so how do you get an advocate? And this is another big like ethical issue. How do you get advocates in the community to buy into advocacy around the population when these folks may also have committed egregious harms? That's the big issue we face in terms of like getting resources. The sort of victim offender dichotomy is blurred. So you've got people who may have done really egregious stuff. We have some interviews where people have, murdered their children, and they're still very lucid about that. Like those days are still really difficult for them. And so you've got a caregiver who's providing compassionate support to someone who has caused harm or death to another person, and the ethical tension that drives in the caregiver, often unsupported in terms of not having standard like bereavement or grief support groups. So I don't know if Bonnie would necessarily be subject to retaliation. We have been given the impression that it's not so much retaliation so much as it's just ignored is the bigger issue. It's just there's no intervention.
Dr. Prost, if I could just add something that maybe might, I guess, help folks understand, if any kind of outside resource that folks come in with immediately stops. So if you're a veteran and you are retired and receiving TRICARE for the rest of your life, if you retired from GM way back when and your pension plan still included, lifetime health care, all of that stops, which seems to make no sense because that would be a cost that the state could, bill back out to these other agencies. But all of that ends during the time of incarceration. If you were on Medicaid, Medicare coming in, it stops. It does, you're welcome to restart it upon release. But while you're incarcerated, any health coverage that you have that's guaranteed to you through work or whatever, retirement, all of that ceases and you switch over to this, I guess, state institutional plan.
And in Kentucky, we are lucky that we have, this model where folks can initiate coverage is like I think you're 30 days out, right? Oftentimes, I think that's the model that we have with our waiver, but that's also anticipating a certain proportion of folks, again, are reentry eligible. So a lot of people aren't going home. So for those who are going home, that's wonderful. And hopefully at least getting the healthcare continuity in place. For those who are not reentry eligible, then those models don't really matter. They are a black box. And I say that in all humility. I've worked alongside the commissioner and administrators and wardens for the past 7 years. These people genuinely care about the folks in their charge. We're unique in Kentucky. We have a lot of very well, rounded, holistic minded wardens, people who genuinely want to see more programming. And even when they advocate at the state level for additional funding, you all know, right? Your social service providers, you're saying like, well, we need to pour money into this because of this vulnerable group, which means that that money is not being allocated somewhere else. And so it's often a hard sell for policymakers. We need to pour an additional $1.5 million into a long-term care unit for our folks in prison, but then we can't build another school in this county, or we can't have a bigger shelter, or whatever it is. This is like, we often make the argument from like a human rights perspective. This is a group that we as a society, we collectively as humans more broadly, have agreed it's okay to discriminate against. So it's like the opposite of like most rights related kind of advocacy. You can't discriminate based on race, sex, gender, disability, the whole thing. But here is a place we allow it. In fact, we'll allow the state to do it and say you're not eligible for certain housing supplements. You're not eligible to live in certain places. You can't take these sorts of jobs. So it's state sanctioned discrimination. Despite whatever positive attributes these people have, right? I don't know if you saw recently a gentleman who was killed, who was sentenced to the death penalty, and he had like commendations from people who were incarcerated with him, from staff who were like, he saved a man's life while he was here, like he's an invaluable part of this community, and you still couldn't get them to like even transmute his sentence to life without the opportunity for parole. So we're always kind of fighting that uphill battle. And I say this there's a lot of social workers in the room. We get a lot of flack working with this group because oftentimes these are folks who may have caused harm to other vulnerable populations that we're also advocating for as social workers. So it can be really gristly. It's very gray. It's not black or white in this space. And I think that, that's one of my favorite things about this work is kind of helping people see past or through, these kind of false dichotomies, which is like a person is a person is a person is a person, and they have inherent dignity and worth.
Yeah.
And that can be really, really difficult in terms of service provision and allocating resources and things like that. And I say that, and I live in Oldham County, and I mean, we've got a prison every 5 inches, it feels like, right? So, Candy wrote a note.
I think we actually have to move on to,
Yeah, absolutely.
yeah, thank you so much. Thank you for sharing your wisdom. Thank you for sharing the practice, all 3 of you. I mean, I think it was, very enlightening, very thoughtful, provoking, and just getting us to think about this, our humanity, with this particular population. And as you said, all of the dichotomies as it relates to policies and practices. So thank you. Thank you, Dr. Webb.
Thank you
Dr.
so much.
Daniel.
We're gonna probably hop off for the second half. I'm gonna ask that Daniel drop the link to the Cirrus project, which is our supporting reentered seniors project that's ongoing. If anyone has questions about that, they can look to that link.
Thank you. Thank you so much. All right. And now we're going to turn over the mic to KCHC. And I think, is that Mona? Will Mona be able to do that?
No, Chelsea's going to go ahead and lead it since
Chelsea's
I wasn't here for the first part of the presentation.
Okay. All right.
And Mona, you absolutely feel free to jump in. I cannot feel your shoes. So guys, also my lovely assistant has woke up from her nap. So if you hear anything in the background, just know that. KCHC's purpose is to train and empower stakeholders and community members to provide hope and education throughout communities. Our goal is to help everyone at every age to age optimally and flourish as they grow, and therefore we partner with the Project Echo to support this effort. And I'm sorry, you can only see the top of my head. Considering the knowledge and information we've learned today, let's share about how it's impacted you and the work you do in your community. Can anybody give an example? I think some people have already put in the chat, but how do you all feel about this? The presenters are gone, and now, you can say, I've ran into this a lot. I am facing this. I know I worked in long-term care social work for a long time, and I received a number of referrals for placements for individuals that were being released. We were a private nursing home, so typically, I mean at all times, the answer was no to those individuals, just because of their background. And I, as a social worker, always had such a disdain towards that. But right, we all work in a system that has rules and regulations, and so that makes it really hard for us. So does anybody else have anything along those lines that you can share? I think Stephanie brought up a great point there at the end of how are we in the helping field? How do we help everybody? There is times you could be working with a client that's looking at reentry that has is post incarceration, and you're spending a lot of time with that individual, and you're to connect them to the much needed resources. But then do you ever say to yourself, okay, I'm investing a lot of time in this, and they were the perpetrator, just kind of like Stephanie said? Does anybody have any experience with that? Can you relate to that? Do you feel that this is one of the hardest populations to work with? In my opinion, it's a double whammy. If you look at released older adults, it's extremely difficult. We know that there's not enough resources for older adults in general. And then you add on top of all of these barriers. We did say that there's 30 days before they can reapply for benefits, but how crucial is that 30-day period to someone's success post-release? And those are the things that I really think about. 30 days isn't a lot, but a lot can happen in 30 days before someone's eligible for benefits, whether it be health, whether it be SNAP. So what do you all think? Anybody got any thoughts?
I mean, for me, I'm not going to be in a direct care role, but I can totally see if I was advocating for somebody that was incarcerated, all the barriers to getting them any kind of resources and assistance. And then I can imagine what it's like when, post release, trying to help them navigate the world, upon reentry. I mean, it just seems like there's a lot of barriers in place to setting them up for success. And a question that I wanted to ask Dr. Prost was, when I was promoting this session, I kept on wanting to say the criminal justice system, but I looked at her event description and she used criminal legal system. And I assumed that was intentional, and I never got a chance to ask her, but changing that from justice to legal, it didn't roll off the tongue at first, but now that I think about it, I can see that it's not about justice necessarily, it's about legal, and those are two different, very different things.
Yeah.
So
I noticed that as well. Yep.
So for me, it's like this frustration of like, how do you support somebody be a whole person and be rehabilitated and then come back into a world that welcomes them and helps them flourish? I mean, there seems to be a lot of competition for that as a goal.
Yeah, and so while we were talking too, this really piqued my curiosity too, because after, and we say post opioid epidemic, but really, are we post opioid epidemic? No. But the number of individuals that have drug related offenses due to the opioid epidemic, what are we going to do with them as they age? Like this is we're running in. I feel like we're on the precipice of something even more, especially anytime as society as we have these things that we identify as epidemics. What are we going to do with that influx of the population? You know, how are we going to be prepared to serve them as people that serve, especially those that are older? I'll give you all an example. So my husband is an attorney, and he recently represented an older adult that was oxygen dependent, was in a wheelchair, and these were drug related offenses. Okay. And this is at the federal level. This isn't state, so it is different. But my husband came home really upset because he said, what we're putting, this man doesn't have long to live. He doesn't, the facilities don't have the resources to care for him. Like, isn't there a better option? And of course, that's what he argued in court. But that got me thinking too, like, it back to what you're saying, Justin, legal versus justice. What kind of justice per se is that? And so, and then to hear about the conditions which people are when they are end of life in a facility, what is that really like? And so the thoughts just kind of build for me, especially as we look, you know, post opioid epidemic. How many older adults are going to be in that exact same situation, you know, aging in prison, and what does that look like? Mona, did you want to share?
Well, I'm sorry that I didn't get to hear the presentation, but I have done ministry with those that are leaving the prison system for a number of years. And I mean, she nailed it right on the head. She said it's hard for even the younger ones to be able to find housing, be able to find jobs and all these things. And then you add the aging to it. And I know one of the problems that we really had was being able to get them Medicaid quickly enough that they didn't go into some type of a crisis because they wasn't getting their medication properly. And so, you know, how are we going to share these types of things? Well, you know, first and foremost, we've got to become educated ourselves on it. And then we've got to go to coalitions, and we've got to go to ministries, and we've got to talk to our representatives, and we've got to let them know that as they're coming out, the legal system has been served. And now we need to practice a little bit of justice, of empathy, if we expect them to be able to flourish and become a citizens, whether they're young or old. And, you know, it's going to take all of us speaking up.
I think that's huge, Mona, that right there, the advocacy. Like, we've got to take this information that we've learned today, and we've got to advocate. There, I know there's more that I can do on my end. And so advocacy, what else do you all think? I mean, the other thing that comes to mind.
Ashley would like to say something.
Yeah,
Chelsea.
go ahead. Sorry, I can't see.
I know
Sorry,
it's
go
hard to
ahead.
see. Yeah.
Ashley, did you want to share?
Yes, so I'm a community health worker. I can't say I haven't had to deal with patients that's come out of prison, because I honestly, don't ask them, because I feel like they've paid their debt. And if I'm here to judge them, then what kind of person am I? I'm here to do my job and help who I need to help. I had an uncle that was in prison. He was drunk driving and killed someone. He served his time. He got out, and people just looked at him like horrible.
Sure.
Yes, he made a mistake, but he paid for that mistake. So who are we to judge somebody that's paid for their mistakes and is trying to get out to get help that they need to be better?
I love you put everything that I was thinking perfectly, Ashley, because I when I think about things, I think about one, advocate, just like you said. It doesn't matter where someone's from, what they've been through, you're going to advocate for them. Two, how are we meeting people without judgment? You know, we don't have to ask those questions. And as soon as they feel judgment from us, how are we going to be able to serve them? And then three, how do we remove this exponential number of barriers? Because every single thing we've talked about is barrier after barrier. And whether it be the judgment coming from others, because that's a huge barrier that you mentioned, Ashley. How do we remove that barrier? How do we help them get the help they need? How do we connect them to services? So I think my big three, what can we do, is advocate. Again, Ashley said it best, meet with a non-judgmental attitude and realize the number of barriers that these people are facing.
Yeah,
Thank you, Ashley.
I mean, I don't know how everybody feels about religion, but I'm a very Christian lady, and I look at it like this: God is the only judge that matters.
Right.
If I'm
Right.
sitting
Yeah.
judging you, then I need to
Yes.
fix it.
Yeah, and it's not our job to judge. We're actually supposed to do the exact opposite. It's and people we're in the helping field for a reason, right? And not meeting with people. You're not going to be successful in this field if you're meeting people with judgment. So yeah, absolutely. Thank you. I think that was a great point. Anybody got anything else before we move on? I could really, I think, talk about this all day, because this is just steamed so many different thoughts in my brain. And if you all can't tell, I'm already a little high strung. So we can go on to the next slide, Justin. Again, advocate, share events in your own community, share your concerns, be a voice for the voiceless. If you take anything today, it would be that advocate and be a voice. Think about who you could invite to a meeting to discuss this. Do you know a decision maker, a legislator, a policy maker that could impact your ability to get this out there and have community conversations? If you're a case manager and you look and you work with a bunch of other case managers, please feel free to include them in the conversation, get the conversation going. And yeah, does anybody have any events they would like to share? Anything going on in your community that you'd like others to know about we could possibly join?
I'd like to mention World Elder Abuse Awareness Day is June 14th. It's actually June 15th, but Kentucky's celebrating June 14th and events in Frankfurt. A lot of places statewide, counties statewide, cities have got their own events as well, but the state events will be from 10:30 to noon at the Capitol Rotunda.
Thank you, Candy. And if you have any flyers or anything on that, if you could absolutely get it to one of us, Justin, or if you know where we can get it, we'll absolutely share that amongst our students and our other colleagues.
Okay,
Yeah,
certainly.
Candy, if you want to share that with me, I can I can share it when I do promotion for our sessions. I'd like to say that the Kentucky MOST Coalition has been working on legislation revisions to the Kentucky MOST form, the Medical Orthoscopic Treatment Form, which is an advanced care planning tool for people with advanced illness. And we've revised the bill, and we've revised several things affecting the ability to have electronic copies that should become state law in July. And so I'll be sharing some events coming up over the summer. If you work with older adults or with people with serious illness, this is a great tool to help them care for the future and their future care. So I'll be sharing events about that in the future.
Thank you, Justin. Anyone else? Okay, I'm done. Thank you all. It has been a pleasure.
Thanks, Chelsea. I wanted to share something with all of you. The University of Louisville Traeger Institute has recently got a clinical trial actually approved by our Institutional Review Board and by University of Louisville Health. And I know that many of you guys, of course, work with older adults, and this particular study is for individuals that are 65 years and older that have type 2 diabetes and have their A1C of 7.5 or higher. And so I'm the PI on this particular grant, this particular project. And I just wanted to let you all know, if anybody that you're serving, anybody in your family, the focus of this particular study is to look at the impact of a very innovative and unique platform. You'll see the picture in there. It's basically a very immersive platform where older adults, they actually get to develop an avatar. And then the avatar actually goes into this world where they learn all about diabetes management, it's chronic disease management. They also have access to peer mentors, and they actually have, so it's both on demand training sessions about self-management, and also things that are done synchronous. So they have they enter in a peer, a cohort, a group of peers. So they get to know each other, and they work and they interact with each other as their avatar, and they get to actually try different things in their avatar body. So it's also can be something that intergenerationally they'd like. So if you know of anybody that's interested, please let us know. There's also going to be a flyer that's going to be sent out with this Project Echo's communication. So thank you very much. And then I think Mona,
Just
you want to
kidding,
go?
I'm back.
Oh, okay.
So guys, I just want to let you all know that we have our Flourishing Together classes. It's a free 10-week class where we're really looking at holistic health, how to prevent and manage diseases such as diabetes, heart disease, and other chronic diseases. If you want information about that, you can go to our website. We are constantly taking referrals or intakes for our next class, so please feel free. And if you have any questions, we can reach out to one of us and we can give you more information. And please share this throughout the organizations you work with, all of this information. We also have the Flourish program where we help manage. We work with older adults to help manage chronic conditions and improve life satisfaction through comprehensive care navigation. So case management, physicians, we have community health workers, multiple touch points to try to really create that holistic care. We also have a caregiver program, and that is specifically for those in the KIPTA region, working with aging adults that are 65 and over that are serving as caregivers. Again, you'll have access to all of these resources. And then my beloved virtual friendly visitor program, if you all are working with anyone that is facing isolation, loneliness, looking for a companion, someone to talk to, we have trained social work students that will visit with them for free on a weekly basis to get them engaged. It's another person for them to talk with, especially for those that don't have anyone. And so the intake is also on our website. If you have anyone you could recommend for that, we have social work students ready to go, and they will call and get them set up. Again, here's our My Health Matters sessions. We meet every Monday from 6:30 to 7:30. Our next few weeks, we are going to be focusing on having fun. Next Monday, Miss Mona will be doing Age Abound. Then we're off for Memorial Day, and you can see the next few weeks we're having fun. We're going to do a museum tour, laughter yoga, a concert, and tap tap. I won't go into the details about what that is, but it's exciting, and please join us. There's also Walk with a Dog. It's in Henry County. They meet monthly at 9 a.m. It's the first Saturday. You can email Mona to sign up, but it's a great way to have a conversation with a physician and also get some good exercise, but a doctor's right there. And he will answer questions you have. I think they usually cover at least one topic specifically as they're walking, but he's also there to answer any questions. And our closing pledge. Everyone read this. You could say it to yourself. We will become an effective state coalition working with community members and community-based organizations to empower our state to become a healthier and compassionate people, something we all need. Therefore, we will practice self-care and model healthy behaviors to our families, coworkers, and members of our community. So just take that as you leave. Take our pledge with you as you're going forward. And our May thought, may you be happy, may you be healthy, may you be safe, and may you live with ease.
And here's our session evaluation. And so you can go on and complete this very short evaluation. And Justin's going to go on and take the link, I think, and he's going to put it in the chat. Is that right? And you can go on and use your smart device, open up your camera and hold it and towards the QR code, and the session evaluations should present, as well as Justin just put it in the chat. And remember, if you are a community health worker who would like to get that CEU, you must do the evaluation. But we'd love to hear all evaluations from all individuals here. It's very short. Thank you so much for coming. All right. Thank you.
Thank you, everybody. I'm going to stop the recording.
All righty. That was a great